disease. And actually really happy to join Dr. Hani in such a very scientific meeting. My talk will be mainly about the pulmonary hypertension from the perspective of a rheumatologist caring with connective tissue disease. My first title slide, and this nice picture showing actually almost 1,050 years picture. It is also drawn by an artist from France, showing the whole of Al-Azhar mosque in Egypt. Al-Azhar University is, I'm proud to belong to this university. It is now celebrating 1,050 years working and teaching, and this figure showing a teacher standing with a lot of students from different countries, sitting and listening for his presentations. And I think I need to take the control of the slides. Yes, this is my disclosure and my agenda. Actually, my agenda including three important parameters from my side as a rheumatologist. I will not present a lot about the management, which is to be usually done by a cardiologist, but we are sharing some decision regarding our connective disease. So I'll give my first objective going to the spectrum of pulmonary hypertension as regard as a rheumatologist, from the pulmonary circulations, what is the pulmonary hypertension for us. The second main bulk will be about the pulmonary hypertension and the connective tissue disease, with the last station about the screening and how to do it and what's the objective, what we can offer for our patients to get a better diagnosis of pulmonary hypertension. Starting from the pulmonary circulation, actually, which is very unique, we have almost 2 or 3 slides about some physiological and anatomical backgrounds. Pulmonary circulation, it is very unique that it is almost contained all the cardiac output. And the main objective of this circulation is to gas exchange and oxygenate our blood from the lung. Pulmonary circulation starts as early as the tricuspid valve passing to the right atrium to a very short trunk of pulmonary arteries that deviates shortly after 1 or 2 centimeters to right and left pulmonary arteries that deviates again with different branching following the branching system of the airway down to the pulmonary capillaries with recollection again forming the pulmonary veins that ends in the left side of the heart. As I said before, pulmonary circulation is very unique, have a very unique characteristic that is a very high flow system circulation that accommodate almost all the blood pumped from the right pump or right ventricle. But this pumping or flow, high flow action is accompanied by low pressure. Almost it's kept as 1/5 of the systemic blood pressure, usually maintained at the level of 14 millimeter mercury at rest. And actually this important low blood pressure maintained the pulmonary circulation, maintain 2 different physiological and anatomical factors. For the anatomical factors, coming firstly from the histological structure of the pulmonary vessels. Pulmonary arteries itself have very thin media in comparison to the systemic vessels, with very thin myocytes or smooth muscles inside this media, which allows more distension and expansion of pulmonary vessels. The second point from the anatomical aspects that maintain pulmonary artery pressure coming from the early branching. The pulmonary artery branches starting as early as 1 or 2 centimeters from the heart, and then again the branches again with great increase in the branching towards the airways, giving a very big vascular area, which in turn give us also a low pulmonary artery or maintain pulmonary artery pressure. The third point, it is the bulk flow, and as the right ventricle pumps blood to the pulmonary vessel, the pulmonary artery, this artery is distend a lot through its sensibility, causing also a lower and extreme increase the diameter of the vessel, causing more or less lower pulmonary artery vessels. The second most important point for the pulmonary artery pressure coming from the active mediators. As in general circulation, there is a lot of factors that causing constriction and dilators, and the balance between these two factors, the constrictor and dilators, give us the sum towards either constriction or dilators. And in case of pulmonary vessels, dilators working a lot more perfectly. And this is the maintenance also of higher concentration of nitric oxide, prostacyclin, bradykinin, and even here the beta adrenergic agonist causing dilatation, not constriction, as happening in the peripheral circulation. All of these factors plus the anatomical factors that maintain a normal pulmonary artery pressure at 1/5 of the systemic circulation. Coming to the definition of pulmonary hypertension, pulmonary hypertension mainly recently defined by parameters, all of them defined by the right-sided heart catheter. Through catheterization of the right side of the heart and the pulmonary artery assessment, a mean pulmonary artery pressure that defined as greater as 20 millimeter mercury in supine and rest, with wedge pressure less than or equal to 15 millimeter mercury, and the pulmonary vascular resistance almost equal or above 3 Woods units. All of them could define the presence of pulmonary hypertension, and all of these 3 measures are assessed by the right-sided heart catheter. Coming for classification, which as a rheumatologist, actually we believe a lot in classification and the staging, which is very important to understand the pathogenesis of our patients, and especially in heterogeneous disease like pulmonary hypertension that could happen for a different causes and different systemic or local diseases. And also staging of the disease is very important for us to grade our patients and define the treatment strategy and response to our medication. So for each rheumatological condition, we have a specific classification system and grading system. If we apply this to a pulmonary hypertension, we have almost 2 important classification system. One of them is connected to the etiopathogenesis and the clinical characteristics of the pulmonary hypertension that could happen for a different reason, which is coming from WHO, published in 2008. That depends on classification of pulmonary hypertension based on the etiology and the pathogenesis. So according to that, we have 5 different classes of pulmonary hypertension or groups. All of them are homogeneous regarding the clinical presentation, characteristics, and etiology and pathogenesis. The first group, which is pulmonary arterial hypertension, which is the commonest form of pulmonary hypertension among patients with connective tissue disease and the scleroderma especially. And this is the only group we can call it as pure arterial hypertension. In the other groups, there is a mixed affection, could affect veins or capillaries or post-capillaries veins and arteries. But group 1 is characteristic by pure pulmonary arterial hypertension. Other groups, we can call it as pulmonary hypertension, not pulmonary arterial hypertension. The second group is mainly attributed to left-sided heart disease. And group 3 is connected to chronic hypoxia or chronic lung disease or lung fibrosis. Group 4 is connected to chronic thromboembolic pulmonary hypertension. And group 5 is for patients with uncertain mechanism of action or multifactorial mechanisms. As I said, for the second second part of the classification system, we need to have grading for our running pathology to define what's happening and what's doing in progression of the disease of our patients. So WHO again have a functional classification for pulmonary hypertension regarding the ability of the patients to functionally able in his daily activity. Class 1 is patient with pulmonary hypertension almost without any limitation in his physical activity, progressing to class 2 if you have a mild limitation or slight limitation of physical activity, and grade 3 if patient with pulmonary hypertension with marked limitations, and class 4 finally patient cannot even practice physical activity without any significant or limiting symptom for his activity. So we come to ending of the first objective. We have a small hint about the anatomical and the physiological factors that maintain the pulmonary artery pressure below 20. And also we have hints about the classification regarding the etiopathogenesis and the functional ability to categorize our patient as regards the cause and as regards of the stage of the disease. Coming to the second objective, which is pulmonary hypertension, in our patients with connective tissue disease, we will speak about some points regarding this group of diseases. Actually, it was very difficult to speak by all of these diseases in one presentation, but I tried to collect the most valuable points about all connective tissue diseases, including different pathogenesis available. We will present some about prognosis, epidemiology, pathogenesis, risk factors, and clinical picture. For the prognosis, pulmonary hypertension itself is an independent risk factor for mortality among patients with connective tissue disease, and also it is a leading cause of death in some diseases like scleroderma. And even if comparing a cohort of patients with scleroderma-associated pulmonary hypertension, they have a survival rate which is lower even than patients with idiopathic pulmonary hypertension in other group of populations. And in 2013, I have a meta-analysis and almost of 22 studies about scleroderma patients, pulmonary hypertension, and they are reported the survival rate of after 1 or 2 or 3 years. It's reported as 81, 64, and 52%, which means, in other words, that almost half of patients with scleroderma pulmonary hypertension died after 3 years of the onset of pulmonary hypertension, which is actually a very bad prognosis. Apart from the prognosis without efficient treatment, we have some studies showing the effect of implementation of pulmonary artery hypertension specific vasodilator therapy, and reported actually a very good improvement in survival rate of the 1 year, almost 94, 93%, and over 2 years to 82 and 89%, and even 3 years improved to 73, 75, which is compared to the era before starting to implement the vasodilator therapy, showing a great change or game changer regarding the survival rates of such group of patients. And also another cohort study studying 29 patients with pulmonary hypertension in case of scleroderma. We found that almost patients treated prior to 2002 have a significant lower survival rate compared to patients treated after 2002, after they start to implement the pulmonary artery vasodilator therapy, which indicates there is a great hope for such quality of patients if we are start to implement the pulmonary artery vasodilator therapy as early as possible. Coming to the epidemiology. Epidemiology actually for pulmonary artery hypertension itself, pulmonary hypertension is almost, it's about 15 to 50 per million. It's a very rare condition to happen in general population. But if you apply this prevalence in a special population like connective tissue disease, you can find a higher prevalence of pulmonary artery hypertension in cases of connective tissue disease. Starting with systemic sclerosis, which is the commonest connective tissue disease with high prevalence of pulmonary artery hypertension, which is presenting as almost 10 to 15% prevalence. And the pulmonary artery hypertension is defined as a leading cause of death in such group of patients, with 2 year survival rates ranging from 64 to 89%. In addition, also a significant proportion of this patient, almost 22% of them, are silent at diagnosis. Most of them are asymptomatic, no dyspnea, no even any finding at the onset of diagnosis, which is very tricky to have actual prevalence of this disease among patients with systemic sclerosis. I would like to just have some brainstorming with you with small questions about the systemic sclerosis, pulmonary artery hypertension. What do you think about the actual definition of pulmonary artery hypertension? It is a mean pulmonary artery pressure greater than 20 millimeter mercury, supine rest measured by echocardiography, and wedge pressure more than or equal 15 millimeter mercury, or a peripheral pulmonary vascular resistance less than or equal to 3 wedge units, or all above or none above. If you can submit your questions in our chat, it will be also valuable even to assess my slides if it is valuable or not regarding your questions. Proceeding to the description of epidemiology among different connective tissue diseases, starting with scleroderma, now going to pulmonary artery hypertension in lupus. Lupus actually in many trials showing that have an estimated prevalence of 0.5% and categorized as the second common cause of pulmonary hypertension after the scleroderma. But if you can look for other older prevalence studies that depending on the transthoracic echocardiography, we can find almost a prevalence reaching to 14%. Majority of patients with lupus pulmonary hypertension are females, almost 95%, and most of them diagnosed at the age of 40 years. And in a very rare situation to have pulmonary artery hypertension as the first manifestation at onset of systemic lupus erythematosus. Coming to the antiphospholipid antibody syndrome, which is actually a very unique disease in our specialty, and also it is very unique in pulmonary artery hypertension. It can cause pulmonary hypertension by two different mechanisms. One of them, it is the most common through vascular occlusion, which is the hallmark of the APS, as 3% of patients who suffer from acute pulmonary embolism will develop permanent pulmonary vascular changes and the chronic thromboembolic pulmonary hypertension. Another postulated mechanism, which is less common than the first one, through left-sided mitral aortic valvulopathy, leading to left ventricular dysfunction and pulmonary venous hypertension. The other more prevalent connective tissue diseases like mixed connective tissue disease also associated with a high percent of patients without actually a clear prevalence, no actual prevalence, and especially in our region, shows a number of patients having this condition with mixed connective tissue disease. But in some reports, depending on echocardiography, showing this as 50%. And in this type of disease, the response mainly is connected to immunosuppressive medications. As regards rheumatoid arthritis, there is no actually published data about the actual prevalence and extension of this lesion among patients with rheumatoid arthritis. And in primary Sjogren syndrome, which is not a common condition to have pulmonary hypertension among this patient, but if it is it usually happening exclusively in females with a very low functional ability, usually class 3 or 4 among patients with primary Sjogren syndrome. Coming to the second point regarding the pulmonary artery hypertension is the pathogenesis. What's the pathogenesis causing this hypertension among patients with connective tissue disease? There is a lot of theories, a lot of mechanisms different from disease to another. I try to summarize the postulated mechanism and the pathogenesis from the commonest one to the least common postulated mechanism or pathogenesis among patients with CTDs. We have some causes related to vascular wall changes, as we said in the anatomical properties of pulmonary vessels, that is thin walls and the highly extendable vessels. So we have some factors that cause thickening or decrease extendability of the pulmonary arteries. We have also other causes that cause vascular occlusion to close the vessels from inside or close even the pulmonary capillaries. And we have another also extravascular or perivascular factors that could affect the contraction and relaxation or dilatation of the vessels, causing the pulmonary artery hypertension. Starting from the commonest one, which is usually the group 1 pulmonary arterial hypertension, due to arterial vessel wall abnormality, which is very common in systemic sclerosis following to SLE and mixed connective tissue disease. The main start coming from endothelial injury happening. There is increased gaps between endothelial cells with cellular apoptosis, endothelial activations, and activation of adhesion molecules that cause chemotaxis or attraction of inflammatory cells from the peripheral blood to invade the vessel wall and increase the clotting and occlusion of the vessel itself. This is a starting point. A second point, which is the remodeling of the vessel wall itself. As we said before, in the physiological properties of the vessel wall in pulmonary arteries. It is a very thin walled and very extendable media and very thin, smooth muscle and smooth muscle cells inside the vessel wall. Remodeling leads to thickening of the intima, increase the intimal proliferation as a response to the endothelial injury. And the second point, it is the intimal proliferation, increases thickness of the intima, and finally adventitial fibrosis that limits the expansion of the pulmonary vessels, that causing a significant increase in pulmonary artery pressure. This is the most common mechanism happening in scleroderma, SLE, and mixed connective disease. The second common disease, which is the pulmonary hypertension due to chronic lung disease and the chronic hypoxia that's associated with systemic sclerosis, SLE, and mixed connective disease in case of pulmonary or lung involvement, as this, all these three diseases are associated with high % of patients having lung fibrosis or interstitial lung disease. Parenchymal lung disease causing scarring and destruction of the lung tissues, including pulmonary vasculature, causing also an obstruction of the blood flow and pulmonary circulation, leading to ischemic changes in pulmonary circulations. The second point is coming from chronic hypoxia, which is associated with lung fibrosis, causing pulmonary arterial vasoconstriction as hypoxia, causing increased constriction signals inside the pulmonary vessels. And hypoxia proposed to downregulate the endothelial cell nitric oxide, which also is the main dilator of pulmonary vessels, leading to disruption of the balance between the dilators and the constrictors toward the constrictor side, causing vasoconstriction and increase the pulmonary artery pressure. For this, the third common mechanism, which is pulmonary hypertension due to chronic thromboembolic pulmonary hypertension, which is happening mainly, according to our patients, in APS or antiphospholipid antibody syndrome. And as we said before, pulmonary thromboembolism cause, especially in case of incomplete resolution of the clot and endothelial damage, initiate a cascade of process leading to endothelial injury and development of in situ microthrombosis. And in this case, actually, of pulmonary hypertension, the main treatment for us is warfarin, as maintained as very high INR, 2.5 to 3 in some cases. And this is actually the most important and never changed toward other mechanism of action till today. The least common, which is coming from the left-sided heart disease, which is a group 2 pulmonary hypertension according to WHO classification, usually happening with valvular involvement in cases of APS with associated ventricular dysfunction and pulmonary venous hypertension. Coming to the second question with brainstorming regarding the pulmonary hypertension in case of systemic sclerosis. What is the most correct answer? If it is usually classified as class 1 pulmonary arterial hypertension, the exact prevalence of the pulmonary hypertension is almost 25%. Systemic sclerosis, approximately, it is asymptomatic at diagnosis, 55% of cases. Early treatment of milder disease may improve symptoms, but didn't affect the survival, or all of the above, none of the above. Please insert your answer in our chat. Coming to the third point regarding the connective disease and the pulmonary artery hypertension is the risk factors. What's the factor that we can look for in our patients that predict the high prevalence of occurrence of this disease in our patients? We'll speak about some factors regarding to the clinical pattern, the diffusion capacity of our patients, some serology and other heterogeneous factors. Starting from the clinical factors, the most important clinical factor is long-standing disease, especially in scleroderma patients. We have data coming from cohort of patients and meta-analysis showing that the longer the duration of systemic sclerosis, the higher the percentage of development of pulmonary artery hypertension, regardless the extension of scleroderma. And we have also the most important notice, the limited cutaneous scleroderma. This is actually taken lightly in some cases. It is a very limited skin extension in patient scleroderma, not affecting too much percent of the skin of the patients. But actually, this group of patients have the highest prevalence of developing pulmonary hypertension in comparison to other patients with diffuse scleroderma, which have been reported in many series and many publications. The third important point regarding diffusion, low or progressive decline in DLCO in patients with systemic sclerosis is a very important factor to follow regarding the development of pulmonary arterial hypertension. And this was demonstrated by many case control. We have 106 patient studies with limited scleroderma, and we have matched regarding the age, gender, extension of skin involvement, but patients with low diffusion regarding the DLCO have developed a higher percent of pulmonary hypertension in comparison to patients with normal diffusion. Again, one question for refreshment. Systemic sclerosis. Most of patients with pulmonary arterial hypertension and scleroderma have significantly more patients with diffuse systemic sclerosis. Limited cutaneous scleroderma has historically been associated with an increased risk of pulmonary arterial hypertension. Low forced vital capacity over DLCO ratio, less than 1.6, highly suggestive of pulmonary arterial hypertension, all of the above and none of the above. Coming to serology, actually for us as a rheumatologist, serology is very important to lead to some diagnosis, but in most cases of our scenarios is not 100% pathognomonic to diagnosis. It is very rare. In a very rare setup, you have what is called as a pathognomonic blood test or serology. But serology actually in explanation and context of clinical scenarios could have a good prediction of what's happening on such a group of patients. In patients with scleroderma, if we have anti-centromere antibodies positive, if you have anti-nuclear antibody positive with nuclear pattern, and also in absence of SCL70 antibodies, this is actually have a higher prevalence of development of pulmonary arterial hypertension. In contrast to other markers like anti-RNA polymerase 3, which is commonly associated with scleroderma, with polymyositis, this group of patients have a higher extensive skin involvement and increased risk of renal crisis, but it is very uncommonly to have pulmonary arterial hypertension. So the presence of these antibodies is take it very cautious that these patients could have a higher prevalence to develop pulmonary artery hypertension. Coming to other risk factors connected to demographic or exercise-induced or some biomarkers, large observational cohort studies actually failed to find any connection about race and the prevalence of development of pulmonary arterial hypertension. So there is no connection actually can be proven regarding different races, but male gender found to have a good risk factor to development of pulmonary arterial hypertension, and males supposed to have a shorter interval between the development of the disease and pulmonary hypertension development, and usually develop a diffuse type of scleroderma and interstitial lung disease. And also older age at onset of the disease of connective disease or scleroderma associated with a greater risk of development of pulmonary artery hypertension. For exercise-induced pulmonary hypertension, actually, which is very important point, I will highlight it also when we talk about the screening. Exercise-induced pulmonary hypertension, it is very important and proved to be a significant marker in comparison to right-side heart failure, right-sided catheterization confirmed pulmonary hypertension. And in one large observational study, patient with scleroderma whom exercise-induced pulmonary hypertension usually developed pulmonary hypertension within 3 years of the onset of exertional pulmonary hypertension. For the biomarkers, we have two sets of biomarkers. One of them is proved to be reliable, which is NT-proNB, which is usually give us reflection about the strain over the right side heart pump, the right ventricle. If there is a strain over the right ventricle, this proNB is supposed to be increased. And another one also connected to the right side circulation, which is hepatocyte growth factor, but is not validated to be used as clinical practice rather than the research protocols. Coming to the last point, the second objective, which is a clinical presentation. We need to remember that a significant proportion of patients, almost 1/4 of the patients, have completely silent, don't have symptoms for diagnosis. That's why clinical picture is not a sensitive tool to pick up patients at early stages. But the most common symptoms that we can think about is exertional dyspnea, fatigue, weakness, and syncope. Enhanced pulmonary components, and could have some murmurs in pulmonary and tricuspid, and enhanced jugular venous pulsations. And the late stage we can find hepatomegaly and pitting edema and right-sided heart failure as a sign of late sign pulmonary hypertension. Again, another question regarding the autoantibodies associated with pulmonary hypertension. Anti-CL70 associated with the development of pulmonary artery hypertension. Anti-centromere antibodies are associated with increased risk of pulmonary artery hypertension. Anti-RNA polymerase 3 antibodies uncommon to develop pulmonary artery hypertension, and nuclear pattern of NA associated with high risk of pulmonary artery hypertension. All of the above or none of the above, please put your answer in the chat part. Now coming to the last station of our slide today, we pass through pulmonary hypertension as a definition and the physiological factors of maintaining pulmonary artery pressure, and with some scope about different connective tissue diseases and the pattern of pulmonary hypertension happening with different connective tissue diseases. Going to the screening point. Screening, there is two important points to highlight in a screening. The first one, which is the aim, why you are screening our patients. The screening actually is very important for two important objectives. The first one is early detection, as we shown in many cohorts of patients comparing the early implementation of vasodilator therapy in comparison to late implementation or patient treated before 2002, before implementation of vasodilator therapy. There is almost a very over 50% improvement in the survival rate, especially after 3 years, which is very important. So we need to have some sensitive tools to pick up this group of patients as early as possible to apply our early treatment. Coming to the second point in screening, which is the screening methods. We have different points here. We can see different pieces like the puzzle. We have clinical pieces, we have echo data, we have pulmonary function test data, we have the gold standard, which is right heart catheter. Right heart catheter, it is the gold standard, but it is an invasive technique. We cannot apply it for all patients. So we need a combination of the first three parameters, clinical, echo, and pulmonary function test, combinations and serology to lead us to select what patients need to be tested with right heart cath without any decrease in sensitivity of this criteria. Starting from the clinical point, I need to present a small case of mine. This is a real case, and for us as rheumatologists, we are seeing this a lot throughout our life with patients with scleroderma. CH is a female patient, 40 years old, with diagnosis of scleroderma almost 9 years ago. Her initial presentation at my clinic that she has almost bilateral hand pain, skin hardening with long-standing bluish discoloration and exposure to cold. There is no systemic symptoms like dysphagia or dyspnea at all, with no significant family history related to her case. Her initial clinical assessment showed bilateral skin hardening that's mainly distal, affecting both hands without any proximal skin hardening. Evident Raynaud's phenomena, small areas of telangiectasias in the face, and completely negative cardiac and pulmonary examination. So nothing to worry about. As regards the investigations, this patient have positive anti-nuclear antibody with nuclear pattern almost 1/4,000. Positive anti-centromere, and the hair chest CT is completely normal. Till that stage, for me as a rheumatologist, patient come to me completely fine, just some skin hardening, Raynaud's, all hair CT coming completely negative. So the main concern of treatment is coming directed mainly to treatment of Raynaud's and cold protection techniques with some medications for skin care, and that's it. But this patient after 1 year start to change her job that require from her side to have different activity, physical activity level. She start to report to me to have some shortness of breath, especially on exercise, or start to move or walk to her job every day. Again, I referred her to the hospital, doing the dimer test, coming negative, CT chest again become normal. So I decided to send the patients to pulmonologist and cardiologist to assess what could explain the cause of this dyspnea in this patient. Cardiologist first do it a normal echo, and they come to me, to my patients. It's completely normal echo. There is nothing to worry about, and this dyspnea is not cardiac at all. And from the pulmonology side, he relied mainly on the CT chest actually. And I remember when I discussed with him, he told what we are referring this patient. The patient already have normal CT chest, which is the highest investigation that we are doing. He do this test which is called oscillometry or spirometry, and also again in the green part, if you can see here in the graph, this is in the green side. So this patient is normal, and this patient come to my clinic again and downstairs. I'm on the ground floor. So again, I don't have explanation for this dyspnea. I take my patient again to them and ask the cardiologist to do 6-minute walk test, which is it's very important for us rheumatologists to do. Because if you are following this patient with connective disease, most of them have a very limited physical activity. So they are always, or most of them are keeping their physical activity below the dyspnea level, which is very tricky. Patient didn't report dyspnea, and he not complain about dyspnea, and also we are not actually stressing this patient to have this dyspnea. This patient start to have the walk test after 3 minutes. She start to have dyspnea significantly and desaturation of her blood. Again, I went to pulmonologist to confirm the DLCO is found below 60% for her age, which is very low. And finally, they are convinced to go to right side heart cath, and thanks God, diagnosis patients for pulmonary arterial hypertension is almost 1 year back. Conclusion from this case that clinical picture was very tricky. Most of patients are keeping their physical activity below the dyspnea level, so we always should ask our patients to do the 6-minute walk test to have triggering the desaturation and dyspnea, which is very helpful to present the clinical finding. But the clinical finding alone, it is very tricky to diagnose or screen your patient based on the clinical finding. Coming to the second important parameter is the echocardiography alone. In a very good cohort analysis, analyzed 419 patients with scleroderma based on assessment of cardiology to define the pulmonary hypertension. Actually, echocardiography alone missed almost 31% of cases of pulmonary hypertension that's confirmed later by right side heart cath, which means that echocardiography alone is not a valid screening tool to rely on without any other parameters that can help in early pickup of the patients. And combining this echo finding to pulmonary function test is very helpful to improve the sensitivity of this tool to pick up the cases very early. Also, there's some assessment scores like caution risk prediction scores that relies mainly on parameters of the forced vital capacity and the LCO, but it is actually not validated to be efficient to use only parameters like to pulmonary function tests. Coming to the most important detect protocol, which will be discussed in a more interesting way with Professor Hani later in the next presentation. This is actually a very good trial, multi-center, international, that measures the different parameters and confirm this parameter validity to be used as a screening tool for detection or algorithm for patients with pulmonary artery hypertension. The starting algorithm actually is composed of 2 steps ending by right-sided heart cath. The first step, it is non-echocardiographic data coming from forced vital capacity, DLCO, and current or past telangiectasias, anticentromere, pro-NB serum urate, and right-sided axis deviation in the ECG. Each of them have different scores. The summation of this score, if it is passing over the 300 points, patient is valid to enter the step 2, which is echocardiographic data. In this data, we rely on the right atrium area and tricuspid regurg velocity. If the patient scored in this stage additional 35 points, the patient is now validated to go through the right side heart cath, which is the diagnostic step, and this is very good sensitive data for detect algorithm. Detect algorithm, actually, it is compared to different assessment protocols. We have the Australians, we have the European Society of Cardiology and European Respiratory Society have different assessment protocols, but there is no significant difference or high significant difference between them as a screening protocol for detection of patient with pulmonary hypertension among connective tissue diseases. Coming to last question today. Detect protocol includes echocardiography, DLCO, right-sided catheterization, all of the above or none of the above. Please insert your answer. Finally, we have to go to the summary and recommendation. Pulmonary artery hypertension or pulmonary hypertension is a significant complication of connective tissue disease and a leading cause, especially in case of this, especially in case of scleroderma. And implementation of screening methods in such a group of patients is very important for early pickup and diagnosis. Clinical assessment alone is not a sensitive tool used for screening in such group of patients, and the best is implementation of a composite scoring protocol, especially DETECT protocol, which have a good sensitivity for early detection of pulmonary artery hypertension. And the most important conclusion and recommendation for this talk and this meeting, actually, it is a collaboration between rheumatology, cardiology, and pulmonology, which is very important in such group of patients and group of disease that have different aspects, needs a cooperation between three different specialty with aiming to improve our patient care. This is my references, and finally, thank you.